Hi everyone! Welcome to my YouTube channel. Guys, magre-react na naman po tayo. This time magre-react tayo sa isang video about cancer. Kailangan po natin ito yung awareness of cancer para makaiwas po tayo. Especially yung mga senior, mga 40 years old pataas. By the way, kung bago pa lang po kayo sa aking YouTube channel, paki-support po. Please like this video. Kung hindi pa nakasubscribe sa YouTube channel ko, paki-subscribe po. At pakishare na rin po sa inyong friends and families. Tara, samahan niyo ako, panoorin natin. Pakinig po tayo ng maayos para makuha po natin yung mga sinasabi niya. Let's go!
In this video, we're going to focus on, in this particular pathophysiology topic, we're going to focus on the clinical aspects of cancer, or, basically just talking about what cancer is, how it develops, and a lot of terminology that's related to this. And then from here, we're going to talk about clinical signs of cancer. So basically, with this video, I'm going to focus more on the first three bullet points, because probably by the time I'm done with these three, there won't be a lot of time left. I'll have loaded you with quite a bit of information. And so I'm going to save the clinical signs of cancer and risk factors for the follow-up video to this. So like I said, so we're going to focus on, have a heavy review on, or introduction into terminology. And in the process of that, I'll cover what cell differentiation is. And by this point in time, you know what differentiation is anyway. Remember, whenever you see that term differentiate, if you've learned this term from me, you've always heard me say, think of this as specialization. Now that's important because you have to look at the cellular makeup of tumors and figure out how specialized or different or weird they are, and we'll talk more about that. And then it's very important to understand the differences between benign and malignant tumors and how they behave, and obviously diagnostically this is important. And then we'll end the presentation by looking at some visual examples of benign versus malignant tumors. All right, so let's introduce this first. So when learning about cancer, you're learning about the number one killer of human beings on the planet. Nothing kills more people than cancer. As you know, there's lots of infections out there. There's lots of accidents. Humans kill each other all the time. Other animals kill us. But in the end, like I said, cancer is the number one killer of people. And, a big reason for that is just because, one thing you have to understand is that when you think about, cancer, tumor development, a big part of this is mitosis, all right? And what I like to call mitosis gone wrong. Okay, mitosis gone wrong, because in many instances, cancer is as inevitable as the process of mitosis itself. That many cells of our body are mitotically active, dividing all the time, and the more cells are dividing, replicating themselves, making genetic copies of themselves, the higher the chance of, that errors can occur that can cause tumors to develop. And then if we expose ourselves to hazardous environments, all right, that really wreak havoc or hinder that cell cycle, we further increase a chance of developing tumors or cancers and so on. All right, so that's something you have to bear in mind, is that cancer is a very prominent part of life. That's why it does take so many people. As hard as that is to say and as bad as it is to talk about, that's just one of the unfortunate facts of life. All right, and basically the first thing you have to understand is this term neoplasm. All right, so basically when you're thinking of the term neoplasm, basically that neo means new. All right, and when you think of plasm, think of tissue growth. All right, when you see that term plasm, think tissue growth. So what we're literally saying here is a neoplasm is a new tissue growth. All right, and that is basically what a tumor is. All right, a tumor is a mass of tissue that has developed or originated in another organ. All right, so and these can occur potentially anywhere in the body. All right, in the brain, in the liver, in the lungs, in the stomach, in the intestines. All right, in connective tissue spaces of the body, within lymph nodes. All right. Anywhere where a tumor develops, that is a neoplasm, all right? It's a new tissue growth, all right? And these new tissue growths can either be benign or they can be malignant, all right? A neoplasm or a tumor that is benign, that's typically a little bit better of a word to see because because basically when you say a tumor is benign, you're basically saying that it's slow growing, that its cellular makeup is very original or as close to the where the tissue it originated from, and the suffix "oma," all right, is a term is basically used when you're describing benign tumors. So, for example, if someone develops an adenoma, all right, an adenoma is basically, remember what adeno means? Remember medical terminology 101. All right, an adenoma, adeno means gland. Okay, so basically, if someone is diagnosed with an adenoma, what you're saying is they've got a benign tumor in a particular gland, and obviously the terminology is going to be a lot more specific than that, but you get the picture. All right, so or someone can develop a lipoma. All right, just a mass of fat. All right, a bunch of fat cells that are growing a little out of control. All right, so and in saying that, like for example, lipomas are not typically that harmful. Not every tumor that a person develops is going to be horribly life-threatening. Is going to mean the end of the world. In many cases, these these benign masses can be relatively easily removed. And in many cases, they can't. All right, we'll talk more about that in a little bit. Now, when we think of the term cancer. Now, cancer obviously is a very important clinical term, but cancer is a word that I think is thrown around just a little too liberally out there, or loosely, or however you want to say it. But basically, cancer is a word that's used to describe malignant neoplasms or malignant tumors. All right. Now, when and then that's where carcino comes in. All right. Basically, we're saying that if you see that word carcino in a term on someone's chart, or in a book or wherever you see it, what we're saying here is that neoplasm or that tumor is cancerous. So if someone has an adenocarcinoma. All right, so basically, remember adeno gland, oma tumor, and carcino cancerous. So what we're saying here is that malignant tumors, cancerous tumors, that's a diagnosis you don't want to receive, all right, because these are the tumors that grow out of control. These are the ones that are invasive, that spread into and through other tissues. These are the ones that cause a lot of damage, all right, and obviously the later you catch these malignant neoplasms, these cancerous neoplasms, obviously the lower the chances of survival. That's why for certain, there are certain screenings that can be done. We do a lot of self-checks on ourselves. There are certain at certain ages you start getting tested for certain things, like mammograms, prostate checks, males and females doing their own self-checks and so on. All right. Now, these malignant tumors, these are the ones that are capable of metastasizing. And basically, metastasis, it's an easy term to understand. Basically, what we're saying here is we're saying that this malignant tumor or this malignant neoplasm is spreading. All right, spreading. And I'm going to talk more about how they spread in a little bit, but basically for now, that's what you have to understand. Whenever you see the word metastasis or metastasize, all right, we're saying, that's not a word that's used to describe a benign tumor, all right? Metastasis is used specifically for malignant tumors, all right? Now, you're probably wondering, well, how do you tell if a tumor is malignant or benign? All right, how do you tell if it's malignant or benign? And a big part of that is, the diagnostic process of this is, first off, a patient's going to, there are typically, now I'm not going to talk about these in depth in this video or really much at all, but there are very common signs and symptoms that are typical to cancers, like people developing tumors, like pain, bleeding, anemia, weakness, loss of appetite, and so on. All right, and then basically once you, as a practitioner, start putting those pieces of the puzzle together, and you start figuring out that, okay, look, there's a good chance they may have a particular tumor or cancer developing somewhere. Then odds are you're probably going to have to do some scanning. All right, and then if you see the mass, whether it's ultrasound, CT scans, whatever you have to do, depending on where you think the tumor is located, and so on. All right. Then, if it's obviously you can get to it, then you biopsy the tumor. Remember, biopsy is when you remove a sample of tissue from the patient, and then you analyze it, you study it. All right. And then basically, when you take a look at this, benign tumors are going to have cells that are highly differentiated, meaning they're going to look a lot like, they're going to look very specialized. They're going to look almost exactly like the tissue that the tumor originated in. Whereas a malignant tumor, the cells are going to look very bizarre, alien. They're not going to look anything like the original tumor that the mass or the neoplasm was found in, and we'll see some visual examples of that a little later on. All right, and then when you see this, I have this term mesenchyme on here just because, for example, there are some tumors that people can develop that are called sarcomas, or a sarcoma. All right. So basically, what the mesenchyme is, that's an it's an embryology term that's typically used to describe more or less embryologic connective tissue. And there are obviously tissues of the body that develop from this. So, but a lot of times, we would say that with sarcomas, that if someone has a sarcoma, that these are tumors of a mesenchymal origin. Like, for example, an osteosarcoma. So typically with sarcomas, so when we say sarcoma, remember mesenchymal, connective tissue origin, and then typically you're gonna specifically see the word root or which tissue that this originated from, because there's lots of tissues that develop from the mesenchyme, the embryonic mesenchyme. So an osteosarcoma would be a bone tumor. All right, so that's something you have to keep in mind there, and then I have these terms here, oncogene and tumor suppressor gene. All right, and I'm not going to spend a lot of time in this video getting into the genetics of cancer, just because I don't think as undergraduate pathophys students, because obviously that's who this class is targeted for, basically, you don't really need to dive a whole lot into depth with that. I mean, if you're, going into immunobiology, you're in medical school, some graduate program, very upper level advanced cell biology or genetics, then you dive more into that. But for pathophys, I mean, you don't really need to get too in depth with the genetics of cancer. But basically, when you see this term oncogene, basically that's a gene that promotes the development of cancer. And then we have various genes in our cells called tumor suppressor genes that are designed to prevent cancer development. All right, now you remember how the cell cycle works. All right, you've basically got interphase, which is comprised of your synthesis phase, gap 1, gap 2, and then mitosis. All right, so remember that if you're thinking of a cell that is, that's stable or labile. All right, remember labile cells, they undergo, this is supposed to be labile, pardon my handwriting, people. Remember labile cells, these are cells that have high rates of mitosis. Stable cells are typically capable of undergoing mitosis, but they don't unless they're forced to, like liver cells, for example. So if someone has liver damage, whether it's via, they remove a piece for transplant purposes, or alcoholism and infection, whatever it may be, and then liver cells are damaged, then the cells will divide to replace the damaged cells. Whereas with labile cells like epithelial tissues, all right, these are tissues that are very high turnover. All right. And then you've got your permanent cells, which are cells that just don't divide, like your neurons and your cardiac muscle cells. All right, but regardless, when you think of cells in the cell cycle here, remember that when a cell is stimulated to when it needs to divide, it's going to go through these gap phases, cellular growth. The S phase is going to replicate all this genetic makeup, and then the M phase is actual mitosis. Now, basically, before a cell passes from one phase to the next, there are these what are called cellular checkpoints that just make sure everything's all right. I mean, if we're going to replicate all of our DNA in the synthesis phase, we we want zero errors in that process. All right, if a cell is damaged, or if it lacks nutrition, I mean, it's not going to grow properly. All right, and basically, if we have cells with bad DNA or that are damaged, and we start making copies of them, you can do the math on how that could be bad news. That's basically how neoplasms develop. All right, so basically, what these tumor suppressor genes do is they essentially take the cell and they, more or less, what I like to say, shut it down, put it in what's called the gap zero phase. All right, and basically the cell's going to try to repair itself, and if it can't, it'll terminate itself. All right. Now, the reason, and if it's unable to do that and it continues to grow, then that's, when a neoplasm comes in. Now, the reason why I say this, because in many cases when you do these biopsies and you run you do a genetic test on these tumor cells, oftentimes these tumor suppressor genes are mutated. One of the most common ones, or probably the most common one that's talked about, or that you see mutations is a gene called the P53 gene. All right, but that's what tumor suppressor genes do, is if there's any problems in the cell cycle, they're designed to prevent these cells from developing and making bad copies of themselves. All right, and then risk factors I'm going to talk about more in the follow-up video to this when with clinical science, but basically risk factors increase the odds, ODDS, and again, sorry for the handwriting, they increase the odds of you developing a tumor. Now, I'm going to say this again, they increase the odds. I do not want you people going out there walking around saying that risk factors guarantee cancer or tumor development, because that's not necessarily true in 100% of the cases. All right, just because a person smokes doesn't mean they're going to develop lung cancer, but you don't need to be a rocket scientist to know that if a person does smoke, and a lot throughout their life, that they increase the odds of developing lung cancer or other types of health problems. All right. Now, the reason why I say this is just because in the business and marketing side of medicine and health, unfortunately, a lot of supplement sales and oddball professionals out there have kind of hijacked a lot of these concepts and terms related to this and put out products and say, oh, look, this will cure cancer or reduce your odds of developing something or whatnot. And you have to remember that most of the majority of those supplements and products are based on anecdotal evidence at best, because they're not heavily regulated by the FDA and so on, or other agencies, and it's very easy to put a lot of those supplements out on the market. All right, so they'll say what they can to try to get you to believe in their products. The other side too is that a lot of times in education, especially at younger ages, we tend to use scare tactics to try to scare the daylights out of people and kids into not doing things. I don't think that's right either, because it's really important to present the facts and let people make decisions for themselves. Because like, for example, in school, you're always shown the infamous picture of the black lung, from a chronic smoker. Yeah, that's not. I mean, we all know nowadays that smoking's not the best idea in the world. Is that going to stop people from doing it? No. But, you inform people, but we say that, look, your lungs are going to look like this, you're going to get lung cancer. I mean, we scare the crap out of people, and that's not a good thing to do. All right. And I mean, and you got to remember, there's lots of things out there that can be considered risk factors. I mean, I don't think cell phones are going to give you a brain tumor. All right. But you gotta be careful too, because a lot of these people that think like that, I mean, they present almost anything like it's a risk factor. I mean, I'm surprised passing gas hasn't become a risk factor yet, or causing cancer, which good thing it's not, because I would have been dead many years ago. But you get the picture here. So risk factors increase the odds. They don't guarantee, but they can increase the odds. All right, because I've known many people who have been just heavy smokers all of their life and have relatively healthy lungs, right? And you hear stories about people that develop, lung cancer, tumors in their lungs, that have never touched a cigarette in their life. All right, so that's something you have to keep in mind. All right, so that was pretty heavy on the information side. So now let's kind of transition into talking about the differences between benign and malignant tumors, and then we'll talk a little bit about what staging is, and then show some visual examples of these. So a benign tumor Basically, benign tumors, like I said, these are typically the less dangerous when it comes to a diagnosis. But you have to remember that a benign tumor, if left untreated, not all of them, but many of them have the capability of becoming malignant. So that's something you have to keep in mind. So even though being diagnosed with benign mass is oftentimes good news, well, good as it can get, it can become worse if left alone for too long. All right. Now, one of the things about a benign tumor is that they are full of differentiated cells. In a benign tumor, the cells are going to look a lot like the tissue that the tumor is growing within. All right. So there'll be some slight differences, and you'll see some visual examples in a little bit. But that's one thing you have to keep in mind. And I'll show you some examples of the malignant side of this, because when you look at a malignant tumor, there's a lot of different ways you can say this. For example, you can say malignant tumors contain poorly differentiated cells, undifferentiated cells. Oftentimes, or sometimes you hear the cells being described as alien in appearance, looking very foreign. They just don't look anything like the tissue they originated in. But you get the concept. Basically, cells in benign tumors look relatively normal. They're just growing out of control. Whereas with cells in malignant tumors, they not only grow out of control, they look really bizarre. All right. Another thing with benign tumors is that they have very slow growth rates. All right, very slow growth rates. Now, how slow they are is obviously going to depend on the tissue of origin. All right, the tissue of origin. All right, whereas with malignant tumors, these are very metabolically demanding. These are cells that are dividing out of control. Malignant tumors grow out of control. All right, they grow out of control. That's why early detection and early treatment is key when people are diagnosed with malignant tumors. All right, malignant neoplasms. All right, because if you leave them alone for too long, there are some cancers out there. Because remember, the word cancer is associated with malignancies. All right, there are certain cancers out there that within a week you could lower, like small cell lung cancer. I mean, the longer you leave that alone, I mean, within weeks you'll be dead. All right, so that's something from the initial diagnosis. So that's something you have to keep in mind. Now, another thing that I wanted to mention as well is this capsulated versus encapsulated versus unencapsulated. What I'm saying here, basically what I'm saying here is that with benign tumors, they're growing within the organ, but they're still obeying the borders of the organ. All right, they're still obeying the borders of the organ. So if you look at, this is supposed to be a liver, sorry. Again, there's a reason why I study biology and not art. So if someone's developing a benign tumor in their liver, what you're going to see, all right, so let's say this right here is the tumor. All right, if someone's developing a benign tumor in their liver, obviously that's bad news because you have cells that are growing out of control, all right, that's not supposed to be there, but the tumor itself is still remaining within the borders of the liver. So basically what a benign tumor does is it causes the organ that it's originating in to expand. All right, it's going to cause it to expand outward. And this is also what makes benign tumors harmful. All right, benign tumors are non-invasive. Benign tumors are not going to grow through and into other tissues. They're not going to directly invade. But what they can do is they can cause, for example, visceral stretching. Okay. Remember, when you see the word viscera, you think internal organs. All right, so they can cause so they're going to cause visceral stretching. Obviously, the more you leave it alone, the more that organ's going to stretch. Now, let's say you've got an artery nearby. All right, now all of a sudden, that benign mass is now pressing against an artery and occluding blood flow to wherever that artery is carrying blood to. Let's say that benign mass is pressing on a nerve. All right, so you're going to have some neurological problems. That's what makes benign tumors dangerous. All right, is when they cause organ visceral expansion like this. This organ is going to press on and put pressure on surrounding tissues and damage them that way. All right, so benign tumors are non-invasive. They do not metastasize. They do their deed by putting pressure on surrounding tissues. All right. Whereas with malignant neoplasms or malignant tumors or malignant cancers, you notice how those terms are being used interchangeably like that. All right. So basically, these are capable of metastasizing. These are invasive. All right, that's bad. All right, so basically with the malignant tumor, what you're going to have is you're going to start out with what's called a primary tumor. Okay, primary tumor. So for example, let's think of, I don't know, testicular cancer. All right, so male is developing testicular cancer and it's left untreated. Testicular cancer often metastasizes. Very common sites in general for tumors that metastasize to are areas like your liver, your lungs, your brain. Typically areas where there's a lot of blood flow, a lot of circulation into there. Your liver has those large sinusoid capillaries in there, so it's easy for large objects to get into the liver. Okay, so a malignant tumor is going to start out as a primary tumor. So with testicular cancer, you're going to have a primary tumor in the testes, and then if it metastasizes, basically what we're saying here are these high-growing, undifferentiated cells of this malignant neoplasm are going to break off and they're going to spread. All right. So basically, what they're going to do is they're either going to metastasize, they're going to get into the bloodstream and then get circulated around the body, or they're going to get into the lymphatic system, and you know that your lymphatic system eventually drains into the subclavian veins, and basically those tumors are going to get into the blood through that route. All right, but regardless, that's essentially how these malignant tumors move themselves around. Now, wherever these cells that are metastasizing, eventually they're going to deposit themselves in other areas. All right, so for example, if you do let's say someone has advanced testicular cancer, you do a chest x-ray and you see all these tumors developing in their chest, you would call these secondary tumors. Okay. Secondary tumors. So primary because the tumor, the malignant neoplasm originated in the testes, and then it branched out, through whether it's through the lymphatic system or the circulatory system. Cells escaped that primary tumor, and then they got circulated to another site in the body where they implanted themselves and then are continuing to grow, and that's what secondary tumors are. And that is basically the invasive nature of that. Now, one of the things that these cells do once they implant and grow, oftentimes, you see, remember malignant tumors, malignant cancer cells have high growth rates. That means they have high metabolisms, all right? So they're very demanding. So one of the things they're going to do is they're going to try to basically literally steal blood and nutrients from, your not just your surrounding tissues, but from your body. And one of the ways they do that is they secrete what are called angiogenesis growth factors. Remember, angio meaning vessel, genesis to create, all right? And basically they're going to literally steal blood and nutrients from your own body, and then that's going to basically feed the cancer cells, and you can do the math on how dangerous that is. And I'll focus on that more in the next video when I talk about the signs and symptoms of cancer. But that's another way that malignant cancer cells behave, is they stimulate new blood vessel growth so they can literally feed themselves. Now, this term here, carcinoma in situ. First off, when you see the word carcinoma, basically what we're saying here, this is a tumor of origin, epithelial origin. So remember, a sarcoma, mesenchymal, connective tissue origin. When we say carcinoma, basically this is an epithelial tumor. Now, obviously, this is not good news because, as you know, epithelial cells, epithelial tissues, have high turnover rates. All right, you're constantly turning over your cells of your epithelial tissues all the time. So tumors that originate in here have a high probability of growing, metastasizing if left untreated or caught too late. All right, now not every cancer, not every malignant tumor just automatically starts spreading right away. So typically, what you're going to see first is you're going to for example, with a malignant melanoma. All right. if you do a biopsy of a mole or take a look at the skin, you're going to see the area where the melanoma is developing. So basically, you're going to see an area of that skin where there's a lot of bizarre, abnormal looking cells. All right, but they haven't started to spread yet. That's good news. All right, that means this is a lot more treatable. All right, so carcinoma in situ, basically what we're saying here is that we have all these alien looking cells that have developed as neoplasm, that have developed into this malignant tumor in this area, but they haven't started spreading yet in situ, in sight, in place. All right, so all these cancer cells are in place and haven't started spreading yet. And then obviously once they start to metastasize and move around, then that's when this basically goes out the window. Because, for example, like when a malignant melanoma, when it metastasizes and it gets into the lymph nodes, remember melanoma, remember melanin is a very black, in its purest form, is a very black pigment. And if it gets into lymph nodes, for example, it's going to be very easy to spot because you're going to see all these very dark areas where these melanocytes and these pigment cells are kind of aggregating and developing from there. All right, so carcinoma in situ. It's a malignant neoplasm that has not started to metastasize and invade yet. All right, again, when you do a biopsy and look at this area, it's noticeable that there is a malignant neoplasm there. It just hasn't started branching out yet. Okay. Now, another thing that's important to focus on when it comes to tumors and cancer, I'm not going to spend a lot of time on this, but this is important to understand as an aspiring healthcare professional, is what's called staging of cancer. Basically, the vast majority of you that are watching this video or that are learning about this, I guarantee you've all heard of this at some point in time anyway. Like you've heard about someone who's diagnosed with a stage 1 tumor or a stage 3 tumor. All right. So basically what staging is basically when you compile information about that neoplasm so you can develop a prognosis for that patient. And remember, prognosis is basically projected outcome. All right, and part of that projected outcome is trying to figure out, okay, what's the treatment going to be? All right, so once you gather information about that neoplasm, about that tumor, and you look at, is it differentiated, undifferentiated cells? Is it a carcinoma in situ? Is it a sarcoma? Whatever it may be. All right, then that's obviously going to help you determine the treatment. And then once you basically diagnose what type of neoplasm it is, and you figure out how you're going to treat it, then you can get a prognosis and you can project the outcomes for that patient. Obviously, the earlier you catch it, the better the prognosis. Now, again, I want to emphasize on this, a prognosis is very similar to risk factors in that, and there's a reason why I'm calling this projected outcomes and not a cure. All right, projected outcomes. I'm saying here that you're figuring out the best road to wander down, but again, a prognosis is not a guarantee. It's a route you're going to travel to help treat that patient with. All right, you have to remember, in medicine, you do not give out guarantees to patients. Do not do that. All right. That's a great way to instill, even in the most minor, trivial situations, that's a great way to instill false hope, and that's a great way to get your pantsuit off if something goes wrong. All right, so just give patients the information, give them the prognosis, give them the outcomes, and then you work from there. Okay. Now, basically, when you're thinking of the staging of a tumor, staging of a neoplasm, you have to think about the major factors you have to think about are the size of the tumor. All right, the size of the tumor, is there nodal involvement, and is there metastasis? All right, is this thing metastasizing? All right, so basically, TNM, tumor, is there a presence of a tumor? All right, nodal involvement, N for nodal, M for metastasis. All right, so basically there are 4 stages that are involved in staging of cancers, or neoplasms, I'm sorry. 1, 2, 3, and 4. And this particular site here, I put this on here because this is the kind of the United States, the Cancer Institute that has all these major facts, these public information, these facts that are involved with diagnosing tumors in the first place. All right, so obviously stage 1 is the best news that you can possibly get when it comes to a neoplasm. No lymph nodes involved. All right, no metastasis, and the tumor is under 2 centimeters. Now, For most of my users around the planet, this will make sense. For us Americans who are, for some reason, not using the metric system, remember that 1 inch equals 2.5 centimeters. So basically this is a tumor or a neoplasm that is under an inch in size, an inch in diameter. Okay, so no lymph node involvement and no metastasis. Now these middle stages here, 2 and 3, basically if someone is diagnosed with a stage 2 tumor, what we're saying here is that there's local node involvement, there's still no metastasis occurring, and basically the tumor is under 5 centimeters in diameter. All right, so if you do this, so basically what we're saying here is that this is under 2 inches in diameter. All right, if we're thinking of stage 3, basically what we're saying here is that there's nodal involvement, so basically it's spread to nodes outside of the local area. So for example, if we're thinking like with a stage 2, let's breast cancer, someone develops a tumor in the breast, there's a lot of lymph nodes in the mammary area, and basically if you catch a tumor early enough, like a stage 2 breast cancer, basically it's still going to be localized within the mammary tissue. It's going to be under 5 centimeters, and it's only worked its way into the lymph nodes within the mammary area or the breast. All right, it hasn't metastasized into like your inguinal lymph nodes or your cervical lymph nodes and so on. All right. Whereas with a stage 3, the big factor with this is the size. All right, so basically, yeah, there's more nodal involvement. It's could potentially be a little more than local, but the big thing here is that it's bigger than 2 inches. All right, and it still hasn't metastasized yet, but obviously now it's getting closer to developing into that cancerous stage. So basically when someone is diagnosed with a stage 4 cancer, now we have massive nodal involvement. It is metastasizing, and it's greater than 5 centimeters. Okay. So basically when someone is diagnosed with a stage 4 cancer, stage 4 tumor, you're dealing with primary and secondary tumors. You notice with these first 3, you're still only dealing with primary. You're basically dealing with primary tumors. Okay. And like I said, I would highly recommend going to this website because there's a lot of very good and down-to-earth information regarding everything I've been talking about here. All right, so that's enough words for you. Let's take a look at some images related to this. So the first 2 images we're going to look at are examples of benign tumors. So this is what a normal liver looks like. All right, so typically with when we have blood flow into the liver, this is going to be, I have to use a different color than red here. Pen color, let's go with St. Patrick's Day is coming up, so let's go with green. Okay, so basically when you look at how the liver is organized, basically what you have here is you've got these central veins and then these sinusoid capillaries branching out. All right, then you've got hepatocytes. There's Kupffer cells kind of right next to these capillaries. All right, but basically that's essentially how the liver is organized, and then kind of branching out from here are going to be lymphatics and so on. All right, but that's basically a liver in a nutshell. I mean, it's kind of a boring organ to look at, just because remember hepatocytes are those stable cells. Liver cells don't divide unless they have to, so they're kind of in a constant state of gap 0 unless they need to divide. All right. Whereas here, someone develops a hepatocellular adenoma. This is a benign tumor that can develop, for example, in some cases with estrogen treatments, or like, for example, it's kind of one of the risk factors of certain birth control medications and so on. All right, but here, a hepatocellular adenoma, so you can clearly see the tumor. All right, you can clearly see the abnormal tissue in this area. Now, does it really look a whole lot different? No. I mean, if you were to look at this in a higher magnification, the hepatocytes would look very similar. They're going to look a little off. All right, but basically what you have here are these cells, they're just growing out of control. All right, they're disobeying the laws of that organ, because you have to remember, I mean, organs kind of have this inherent size to them. You know, your heart, your liver, your stomach. All right, and basically once all the space is filled within the organ, all right, that's it. There's no need for cells to divide. So in this benign mass here, these cells are disobeying those those kind of innate mechanisms and growing and causing the expanding nature of that of the liver in this situation. All right. So basically, that kind of innate nature of obeying borders is what's called contact inhibition. All right. When all the space is filled, when all the cells are contacting each other, they don't divide. So that by them contacting each other, that's what contact inhibition is. All right. So obviously, this area of the liver is not obeying that, and a benign mass is developing. Okay. Now, typically, this is something that can be treated with surgery, radiation. All right, depending on the how deep the tumor is, where it's at, and so on. But you get the picture here, because you can look at this. The point I'm trying to make here is that this tissue looks very similar to the tissue of origin. Obviously, some different characteristics, but you get the picture. This is an example of the parathyroid gland, a parathyroid adenoma on the right here. I mean, these two almost look like identical snapshots of one another. All right, but one of the big differences that you see here, remember, what do these white ping pong ball looking cells look like? Remember, those are adipocytes. Those are fat cells. All right, and one of the things that you'll notice here is that with these parathyroid adenomas, there's typically less fat kind of in the spaces or areas of the the parathyroid glands, which should make sense because these cells are growing out of control. They're a little more metabolically demanding. All right, they're going to use up more energy in the area. All right, but basically, it's hard to tell the difference between these two, without doing some very in-depth histology and learning about this. All right, but another thing you're going to see, increase, fibers developing in the area as these cells grow and so on. But basically, with this parathyroid adenoma, the parathyroid glands are going to enlarge, right? In the previous example that we looked at with the hepatocellular adenoma, the liver is going to enlarge, and that's a big reason why if somebody dies and an autopsy is done on them, that's why they weigh the organs, because typically organs have a certain weight to them. But if all of a sudden the liver is a pound heavier than it should be, then that'll obviously lead the pathologist to investigate further. All right. Now, something you have to remember about adenomas as well, whether they're malignant or benign, in many cases, this can be a little goofy. I'll talk about this more in the next presentation, but oftentimes tumors that develop from glandular tissue often secrete hormones, right? And hormones in excess. We kind of obey the laws of negative feedback. Now, when this happens, this can create what's called perineoplastic syndrome. All right, so basically, if someone is pumping out high levels of a particular hormone, you're going to see the clinical manifestations are going to be the effects of that hormone. Now, I say that, I'll talk about that more in depth later on, not in this video, but the next one. I'm saying that because let's say someone is developing an insulinoma, all right, a tumor that's secreting insulin. That person is going to be very hypoglycemic. They're going to have low blood sugar levels. In this situation, this person may crank out excessive amounts of parathyroid hormone, all right, and make them hypercalcemic. All right. So basically, this could throw off the initial diagnosis because, the physicians are going to figure out what's making them hypercalcemic, why their blood sugar levels really low. In certain lung cancer, some people throw out excessive ACTH and crank out and create what's called Cushing's syndrome. All right, so that's something you have to keep in mind with that, is that oftentimes these can throw off the diagnosis. But again, you get the concept. Sorry for that side rail again there, but you get the picture here that with benign neoplasms, benign tumors, they look almost exactly like the tissues they originate from, and they just cause expansion of that tissue. Whereas with malignant tumors, this is a pap smear from a postmenopausal female. All right, basically when you look at these epithelial cells of a pap smear, epithelial cells, especially squamous cells, are the most boring cells to look at. They're flat, there's nothing to them. All right, I don't think you need me to sit here and explain that this is a little off. All right, this image here. So basically, these cells are very alien in appearance. These are those undifferentiated cells that I was talking about. All right, so basically, this is gonna throw a red flag, throw up a red flag, and you're gonna have to go from there. And then obviously, then you have to figure out, okay, well, we have to do staging now. All right, what's the size of this? Has it metastasized? Has it worked its way into lymph nodes? If so, is it just local nodes or further? If it's metastasizing, now we have to deal with a primary and secondary tumor. So this would be an example of a primary tumor that's developing, from the cervix. Okay. But you get the picture here. I mean, like I said, this doesn't warrant a lot of explanation that this looks a lot different. With the lungs, all right, with lung cancer. So basically, this isn't a picture of a normal lung, all right, because basically from here on over, this is an example of emphysema. So basically with emphysema, people have obstructed airways. They have these mucus plugs that plug their bronchioles. Then they have hyperinflated alveolar air sacs, which is what you're seeing here. So you see these big spaces that are filled, and that's why people with emphysema have an increased residual volume. They have too much air left in their lungs. All right, but here on the right, this is a relatively unaffected area of lung tissue. All right, remember, alveolar air sacs are just simple squamous epithelial cells, and then surrounding them would be capillaries, and then separating the capillaries and the alveolar air sacs would be the basement membranes of the endothelial and squamous cells. All right, but this is what normal lung tissue looks like. Again, you take a look at this. This is a small cell carcinoma, probably the most aggressive form of lung cancer a person can get. Bad news. Now remember, carcinoma. Remember, what are we saying here when we're saying carcinoma? This is a tumor or a neoplasm of epithelial origin. Remember, the lungs are predominantly made of, or the internal aspects of the lungs are predominantly epithelial tissue, these alveolar air sacs. Now, this is obviously not normal here. All right, basically, with small cell lung cancer, you develop you have these small cells that grow at incredibly rapid rates that secrete these various proteins that have these highly condensed nuclei. All right, and that's what you're looking at here. Is this all these rapidly growing condensed cells? All right, and like I said, this grows at a very rapid rate. But you can see the difference, from the normal lung to the cancerous lung over here. All right, so hopefully these images illustrated the point of, benign tumors pretty much looking like the tissue that they came from, whereas malignant tumors are very alien, bizarre in appearance, and then that's where, like I said, when one of these are found, whether it's benign or malignant, that's where staging is very necessary so you can figure out the appropriate treatment. All right, so that is kind of my overview of just like I said, basic overview of neoplasms, tumors, cancer, what this is all about. Remember all that very introductory but important terminology related to this, because that's stuff you're going to see all the time. All right, and then, and I forgot one more thing. I forgot I had an image of carcinoma in situ. All right, so again, carcinoma, epithelial. So this is an example of an endocervical tumor here. So basically, you can look at this. It's pretty obvious where the tumor is. Now, you'll see here that these cells are very alien. They're very bizarre. They look nothing like the cells in the environment that's surrounding them. All right, this is a brand new weird tissue growth. All right, this is a malignant neoplasm, but it hasn't started to spread yet. All right, so you can see how this malignant neoplasm is still localized to the area. All right, so remember, carcinoma in situ, it has not started to undergo metastasis yet. All right, it has not metastasized. Now, like I said, a malignant neoplasm, obviously is not good news, but this is, if there's any news you want to get related to that, this is it, because then you can, obviously, if you catch this before it spreads, obviously the prognosis is hopefully going to be much better. Okay, so that's an example of carcinoma in situ. My apologies for forgetting that. And then these are the images that I used in this presentation. All right, so that is my introduction to cancer.
Guys, napakaganda ng video na ito. Marami tayong natutunan tungkol sa cancer. Yung iba't ibang klase ng cancer, kung paano maiwasan o paano kung kailan tayo kailangan pumunta na ng doktor. So, mayroong cancer na yung stage 1, stage 2, yung pwede pang gamutin. Yung medyo delikado na malala na yung stage 3 at saka stage 4. Pwede pa rin gamutin pero it takes time. So guys, especially yung mga 40 years old pataas, kung mayroon kayong mararamdaman na unusual, yung mga bukol-bukol na yan, dapat po wag natin i-ignore. Most of the people kasi ini-ignore lang, especially kung kaya pa naman. Very common po sa atin yung yung mga Pilipino, na kung kaya pa lang hindi sinasabi sa kahit kanino, tapos tinatago lang. Takot naman pumunta sa doktor minsan. So, yan, para humaba ang buhay, kailangan natin talaga maging conscious, maging aware po tayo sa mga kinakain natin. Dapat yung health conscious tayo. Kung pwede yung lang, isda, gulay, fruits, iwasan yung karne, baboy, yung mga cholesterol. So, mahalin po natin yung katawan natin dahil ito lang po ang binigay ng Panginoon sa atin. Dapat ingatan po natin. Huwag magsigarilyo, huwag mag-inom ng inom. Huwag abusuhin ng katawan. Guys, hanggang dito na lang po tayo. Sana marami kayong natutunan sa video na ito. By the way, kung bago pa lang po kayo sa aking YouTube channel, please paki-support. Please like this video. Kung hindi pa nakasubscribe sa YouTube channel ko, please paki-subscribe po. At paki-share sa inyong friends and families. Salamat po. See you in my next video. God bless us all. Bye for now. Salamat po.